This podcast is brought to you by the Prospect Research Institute, a vibrant online learning community providing high-quality educational content, the opportunity to connect with peers, and an outlet for new ideas in the field of nonprofit fundraising research.
The first thing you really have to learn is HIPAA, and you really have to understand what you can and can't do. And every hospital system interprets HIPAA a little differently.
Welcome to Prospect Research Chat Bites, a podcast by and for prospect research professionals. I'm Jennifer Filla. Today, I'm talking with Chris Mildner, Senior Philanthropy Analyst at Legacy Health.
Hello, Chris. Thank you for joining me today on Chat Bites.
Hi, Jen. I'm so glad you invited me.
So I really wanted to talk to you today about what it's like to be a prospect researcher at a healthcare organization. But first, I'm hoping you'll share a little bit about yourself. I'm always curious how people come into prospect research. What's your story?
Well, it's back in the primordial era of prospect research. I had been working at Motorola down in Phoenix in workforce diversity programs, moved to Tacoma, where nobody was doing anything in workforce diversity programs. But I had done a lot of socioeconomic research when I was at Motorola. And so I saw the ad for prospect research, and it sounded like I had the right skill set for it. And I thought, well, I don't really know what this is all about. So I put my resume in, and they invited me for an interview. And they asked me, about my skills. And they said, well, it seems like this is a good match. We really don't have anybody who has a lot of experience in this that we've interviewed or that's applied. And so they hired me, and I loved it. It was like writing little mini bios all the time. And that was back when we were doing research mostly out of books. We had dialogue on dial-up, and it was really slow and horrible. So that's how I got into it. And since then, that was at University of Puget Sound. And then I went to Willamette University, both of which are small liberal arts colleges. And then from Willamette, I went to Oregon State University, and then on to Portland State University. Oregon State is a land, sea, and space grant institution, and Portland State is an urban state college. And then from there, I worked for a small K through 12 private school for a while, and did actually some fundraising while I was there, which was new and different for me. And then from there, I went to Oregon Health and Science University, which was my first experience with healthcare fundraising. And that's a big teaching and research hospital in Oregon. And then I worked at Clark College and helped them with their first campaign in probably 20 years. And that's a community college. And then from there, I came here to Legacy Health, and we have 7 hospitals. They're urban and rural, and we have a smaller teaching and research component than OHSU, which is really a teaching and research hospital / university. And so that's how I got here. I've seen lots of technology changes since I got into prospect research. I'm thrilled with the more access to more information. That's great. And I'm on this job is my 5th database conversion, and I've seen databases grow from, basically more than a glorified Excel spreadsheet to monsters. And which is also great because we can do lots more data mining, we can do lots more reporting and analysis. So
Wow, so this is a broad experience.
yeah.
College, community college, healthcare, teaching hospital. That's a lot of different types of environments to be researching in.
Yeah, but research is research. A lot of the information you provide is the same no matter where you go. And a lot of the processes are the same.
It's interesting. When I worked at Thomas Jefferson University and Hospital, one of the things they were beginning to implement was a kind of VIP program. So identifying patients who were in the hospital at that time who were either existing donors or prospective donors. And it was from the frontline fundraiser perspective, quite a challenge to get the right skill set to be able to do that, to go into the hospital room. But it was also the challenge for data, because we hadn't been pressed for that kind of current data. What kind of data challenges are a little different in a hospital environment for you than they were at the community college or at a university?
The biggest challenge is duplicate records, actually, because we get a daily patient import, and previously we hadn't gotten the patient ID number. Well, it's not actually the real patient ID number. It's a overlay that they do so that we don't see the real one because of HIPAA. So we weren't getting that. So we would bring in records every day and it would create duplicates, and cleaning them up was just this ongoing nightmare. Now we get that number that we can match to, but we still have lots of people who haven't been seen since we started doing that.
Oh, wow.
Lots and lots of duplicates. And it's frustrating because they just have to put in the address slightly differently than we have it in our system, and it creates a duplicate. So that's the biggest data challenge I think we have, is keeping our data clean. We don't have a VIP program. We had one at OHSU, but they had been doing research there for a very long time. So they had a really good list of people, so that the data would come into the warehouse and they would match them, and it would come out in the daily patient report. Oh, this person is assigned to Joe Smith over in the School of Medicine, and that person would get a notification. But we don't do that here because we have a different. They were opt-in, so in case people don't know the difference with HIPAA, which is like FERPA at colleges, only much more restrictive because of private healthcare information. You can either be opt-in or opt-out. Opt-in means that patients choose to get information from you. So when they come in as a patient, they sign a thing and say, yes, you can send me stuff. Opt-out means they have to notify, we just send them stuff, and then they have to notify us that they don't want it. So because we're opt-out, we have a much more restricted visit policy. So we don't visit people unless we already have an established relationship with them.
Wow. That's an important distinction.
Yeah.
I don't think I quite realized.
Well, yeah, and frankly, I think people who don't have a relationship with someone at the hospital, when you're in the hospital, you're not at your best. You generally look awful. You feel awful. You really don't want somebody you don't know coming in and saying, hey, how are you?
It takes a very special person who can bridge that carefully. You're right. If you're getting brain surgery and you're recovering, I just can't even imagine walking in someone's room without a relationship. But it happens.
Yeah.
So
our patient daily import now is they only get notified if the person's already a donor or a board member, and that way they can decide, do I have a firm enough relationship to go visit this person? We had a program previously where we were a little more liberal, and we had a couple of people who were not happy about being visited, so we revisited that and said, I think we need to be more restrictive.
Yeah, I can imagine. So what is your team like? How many researchers, how many frontline fundraisers do you support? What's the office like?
It's probably one of the best offices I've ever worked with. It's very collaborative. Everybody's willing to pitch in and help. Everybody's willing to share knowledge, experience, time. Everybody's very supportive. We have a lot of expertise. There's no fighting over prospects, which is really nice.
That is nice.
We don't have any prima donnas, so that's really nice. And so there's 4 of us. There's my supervisor. She's a working supervisor, so she also does research. Me, I'm the senior research analyst. Our research associate, and then we have a support person who does a lot of data entry, and she does things like the obituary lookups for us. It's very important for us to keep on top of people who are deceased. As a healthcare system, there are tend to be a little less forgiving if you don't notice that their spouse has died.
Yeah.
Because they expect you to know that. We do get notifications from the hospital, and those people get deceased, but there are a lot of people who we have in our system who didn't die in hospital, so we don't know. So we have to keep on top of those obituaries.
That's kind of a dilemma, right? The patient sort of expects you to know because you're their hospital, and yet you can't know because of HIPAA. That's tough.
Right. Well, like I said, we do get notices of people who die in the hospital.
Right.
But if they go home and then die, we have no way of knowing.
But they still feel like, well, that's my doctor. I went to that hospital. They think it's all connected. I can imagine myself feeling that way.
Well, I know when my mother passed, I called her doctor's office to let them know, and they were surprised. They said hardly anybody ever does that.
Yeah, I'm sure. It's not the first thing on your mind, but you, being a data person, are well aware of what that means.
Uh-huh.
Yeah, interesting. So what are the frontline fundraisers like that you support? Are there different issues around healthcare that you're focused on for them?
Like I said, the biggest challenge is the restrictiveness in terms of who we can contact. So when I was in higher ed, we had a huge number of prospects because we had, even at a smaller liberal arts college, you have years and years of people who have graduated. So here with healthcare, it's less, there's less in terms of major gift prospects. And it's harder to get that connection because if they've been a patient and they're not a donor, we can't call them according to our policy.
Wow, that's really tough.
Again, because we're opt out. So that means we have to find a connection. So we spend a lot of time trying to find, do they know one of our board members? Do they know one of our major donors who would be willing to provide an introduction? So we're always looking for those connections. We spend a lot more time looking for those than we did in higher ed, where if you're an alum or a parent, you can pick up the phone and they kind of expect you to call. So
how does someone become a donor? Are they receiving mailings from you? Or?
Oh, yes, we do lots and lots of mailings. We have an annual giving program that does a lot of direct mail. We have e-blasts. We have a giving newsletter that goes out, and everything has an appeal in it.
Okay.
So we do a lot to acquire new donors. And we have a really robust employee giving program as well.
That's wonderful. And you can contact them.
Yes. We're allowed to contact them.
So what kind of wealth screenings do you do? Because that's a lot of patient data that isn't donor data. Like, how do you sift through the differences there?
Well, when the patients come into our system, we have worked very closely with IS on the hospital side to reduce the number of patients that we don't want to get. So for instance, all of the Medicaid patients are limited out. We don't get those. We don't get patients who have, for instance, a jail or DHS as their address. So we try to limit it that way with as much as possible. And then everybody comes in and they go through a screening, and we get a huge number of unable to rates.
Mm-hmm. I bet.
And a lot of those people are actually people who live in assisted living because they don't own anything.
Okay.
So that makes that a little more difficult. So we do a daily screening. So every day the patients come in, they go through the screening, and then they come into our system. And then, we don't sift through them every day. Periodically, we go through and say, oh, who's $1 million plus person that we can research and bring forward that we can find a good connection to, or who has already been a donor, and move them forward to our fundraisers. And our fundraisers are great. They're really willing to work with their volunteers or call directly when they're able to do that and pick up the phone and just go. So
So are you using any kind of relationship mapping technique or tool?
No.
So it's all by you.
Yeah, well, we don't really have the robustness of data in our system to be able to do internal relationship mapping. So we do get some from the screening, but usually they're not connected to people that we know. We don't get a lot of people who are on various boards.
Okay.
So
Yeah. There has to be data points. So internally, you have a way to link records, probably, but that's
yeah.
about it. Yeah.
And when we find that, we do link them. We create the relationship record for them.
So I guess I was going to ask you about any specific fundraising challenges in healthcare, but you've identified at least one. If you're opt out, you need to be very careful about how you contact, if you contact. Is there anything else that's like a fundraising, something that's different in healthcare?
Because healthcare is not a fun experience for most people. I mean, college, most people go through, they have fond memories of their college years. So there's that happy feeling when you call them.
Mm-hmm.
Healthcare, not so much. So unless somebody's life has been saved, or a close friend or relative's life has been saved, or we're doing some research on something that's close to their heart, say their family has an issue with cancer or with brain trauma. One of our research areas is brain trauma. You know, they look at it as a service, and I've paid for my service, and I probably feel like I've overpaid for my service. So why should I give you more money? And so there's that kind of resistance.
Mm-hmm.
People are much more likely to give to education or religion or the arts than they are to healthcare. And also, I think people don't want to think about healthcare. Some people think of it in terms of, this is a good thing for the community, and I like to contribute to the community. For instance, Legacy is the biggest provider of charity care in the Portland metro area. So we do have people who like to contribute in that way to help other people have access to healthcare. And for instance, the other thing, like recently we opened a mental health emergency room called Unity, and it has beds and emergency. So it's an emergency room, but then you can get admitted to the beds, or you can get referred to one of our community partners who have offices in the building. Mm-hmm. And this is our big fundraising project. And because mental health is very important in the community, and we have a lot of people in the community who are very interested in that, it was relatively easy to get interest going in that and do the fundraising for that.
Well, that's great. So are you ever reaching outside your own data in terms of patient data and donor data to find donors for projects like that?
Occasionally. So when we did that project, we were looking at other people who had given to mental health nonprofits in our area. We were looking at, my boss has the world's best memory and has done a lot of family trees. And so she would remember, oh, I remember there's some issue with that in this family from when I was in another job. And
wow,
or I would remember something like that. But she remembered a lot more of that than I did. So that's part of it, with that institutional knowledge. Also, we had some of our fundraisers with the same kind of knowledge.
Wow, that's great.
He also brought a lot of people to the table. And then they were all really good at working the people that they were soliciting, building those relationships with, and saying, who else might be interested in this? And so we had some volunteers who did salons in their homes, and invited people who came in, and many of those people also became donors. Some of them major donors and some of them at a lower level, but we acquired a lot of donors with that project.
That's a great example. Yeah, so as a nonprofit hospital, you're providing services, but you're also providing charity care and community service.
Yes.
It's something I hadn't really thought about. I thought about healthcare because I've been to the hospital, but there's much more.
And hopefully you had a good experience there.
I've had both.
No.
Haven't we all?
Yes, unfortunately.
So one of the things that I immediately thought when I spoke to you, communicated with you, realized you were in healthcare, I thought politics, because there's just so much turmoil right now in politics, and healthcare, well, at least, in the beginning and certainly at different periods, has been like top on that list. What is it like to be a fundraising researcher in a really political turmoil, I guess, with things changing all the time and different directions being taken? Has it affected you?
It doesn't affect philanthropy as much, but the hospital, for instance, when the ACA came in, we acquired a lot more patients who had coverage. So people were coming for more visits and more hospital stays because they now had coverage to do things that they couldn't do before. So now with the changes to that, we're looking at, possibly a decrease in that area. So, so the right now Legacy is in a wait and see, tighten the belt buckle mode to see what's going to happen in Washington. I think that some of the ways that it did affect us. So, for instance, under the ACA, if you were in the hospital and then you came back into the hospital again within 6 months, there was a penalty because supposedly you're supposed to be working with those patients to not have them be readmitted. Now, unfortunately, it wasn't written that they got readmitted for the same thing. So if you came in because you were having a huge allergy attack and you needed a shot, and you came into the ER, and then 3 months later, you broke your leg and got admitted, that counted.
Oh, wow.
There wasn't anything we could do to prevent you from breaking your leg. But so what that caused Legacy to do was put even more aftercare focus on. So they opened some new positions for follow-up, particularly people who were on Medicaid and Medicare, which were the people that tended to be the biggest users of the ER because they didn't have regular doctors and regular follow-up care. So they instituted more follow-up care programs, and so we did some fundraising for that.
Okay, and just in case people aren't aware, ACA is the Affordable Care Act that was put in place under Obama, right? Make sure I'm correct too.
Yeah, you're correct. That's right.
Okay, so it's definitely had an impact. What about donor motivations? I had been reading that the very wealthy have become more ideologically extreme. Have you found that your frontline fundraisers are concerned about political interests, or not much?
I don't think anybody has said anything about that. They do like to be aware of, is my donor a Republican or a Democrat, so they know not to put their foot in it either way. But I think the big change is not so much politically, but in terms of donors wanting to know, where did my money go? How was it spent? Was it spent well? They're much more interested. They don't just throw money at you anymore and say, oh, do something good with it. They want to know what you did with it and how, and was it effective? So it's individual donors have become much more like foundations in terms of wanting to know what their ROI is and that their money was well invested.
Okay, so when the politics is impacting the type of services you provide, it's still more about, when they give to that, how did it work? What's the measurement for success?
Although I did have somebody say to me, one of the fundraisers said that one of their donors raised the question of, well, now more people have insurance, so you're not providing, and our charity care did go down at that point, so you don't need as much for that. And the answer was, well, we always need that because what the government pays us for people and what insurance pays us for people, it's like tuition. It doesn't cover the whole thing.
Right. Especially in your case.
Yeah.
Because that's your mission.
Mm-hmm.
Well, that's so true. And also it's volatile. I mean, they can change the laws at any moment.
This is true.
And then,
Hopefully they won't change them too much.
yeah. It's interesting, the whole debate around it and the financial impacts for the healthcare and for the patient. I just can't imagine working in an environment that was changing like that all the time. You'd have to be pretty nimble.
We do. Legacy is very nimble. One of the things they did when the ACA came in is they set up a partnership with an insurance company so that now that we can offer insurance plans as well, because we hadn't done that previously.
Wow.
To broaden our access to patients and broaden their access to healthcare through us, because we do have 7 hospitals, and we're one of the larger healthcare providers in the Portland metro area.
Ooh, and maybe make some profit that can be reinvested.
Yeah, hopefully.
Interesting. You never know. Although, well, that's a whole nother data topic.
Yeah.
Insurance.
I don't know enough about it to speak knowledgeably.
Yes. Oh, insurance is fun. So I'm curious, you've worked in a number of different environments, and you mentioned the culture at your particular institution now. In terms of, if I'm a prospect researcher and I'm thinking, well, what will I do in 5 years? How do you view the differences between university, community college, and healthcare or hospital?
I think it depends on the size, really, because when I worked at OHSU and it had the different schools, the School of Dentistry, School of Medicine, different departments within the School of Medicine. So there was more, it was like a college. There was, and it actually, well, it is a university. So there was more competition for donors internally, because this person had given to this person had given to that, and people tended to want to more arm wrestle over them because they were established donors, and it's always easier to work with an established donor than to bring a new one on board. Here, because we're still in acquisition mode for our major donors, really. I mean, we have a good number, but obviously we always need more. So we're still in acquisition mode, and our fundraisers tend to be more collaborative, where they'll say, well, I think this person might be interested in this and this, so let's talk to them about both and let the donor decide if they want to support both or one or not at all, and which we hope doesn't happen. So I think here, at least, it's a little more collaborative because you don't have the School of Business competing with this College of Arts.
Sure.
And that was one thing in higher education fundraising that always sort of puzzled me, that it was like, well, this person graduated from this school within the university, therefore they're my donor, but they have no history of giving to that. All they're giving is to the arts. Or maybe it's just we're trying to be more donor centered now, hopefully.
So donor motivation is key in your office. Like,
yes.
Why do they want it? Or donor interest.
Yes. And a lot of times we don't get specific information about their diagnosis. So we might know that they were treated for cancer, but we don't know what kind of cancer. So we have to do more generic fundraising, whereas in education, you know specifically what that person's major was, and you can solicit them first to support that. Here, you could have 1,000 different kinds of cancer, and all we would know is that you were treated for cancer because we would see the treatment area, not the specifics. So we can slightly target our mailings, but not really tailor them the way you can in higher ed.
So this withholding of information is making you perhaps a little more nimble.
And a little more cautious.
You have to listen.
Yeah.
That's great. That's very interesting. I was kind of curious about all that. Is there anything you would any tips you would offer to someone who is considering joining healthcare or who has just crossed over?
Just be the first thing you really have to learn is HIPAA, and you really have to understand what you can and can't do. And every hospital system interprets HIPAA a little differently. As I mentioned before, there's opt-in and opt-out, but then within those, there's different gradations of how they interpret those and what they allow their fundraisers to do and not do. So that's the first thing you really have to understand. Also, you have to know that you can't put any health care information into your database unless it's publicly acknowledged. So if I find an article that says, somebody has breast cancer, I can note that because I added also the document into the database that says this person has breast cancer. But if the patient tells you, I have breast cancer, you can't put that in to your database because that's a HIPAA violation. So you have to know all these ins and outs of different things. And so contact reports, we have to be really careful. And with new fundraisers coming into that, that's the first thing we have to tell them is you can say who their doctor is, but you can't put their specific diagnosis in unless they have publicly spoken about it or it's mentioned in an article or something.
Sure. Yeah. Tricky. Data collection then is on your list of priorities.
Mm-hmm. And then, just the patient screenings are going to be much more frequent because you're getting that data every day. And so you have to set up a plan for, okay, we have all this stream of information coming in constantly. How often do we want to review it to find new names and bring them forward? So that's sort of how does your office work and how do you bring new prospects forward within your office? Those decisions have to be made.
So if someone was craving to do more proactive research and really just couldn't make headway at their current organization, if they move into healthcare, it almost sounds like it's a must. Like you're going to have to be proactively identifying prospects.
Yes.
That's great to know. Well, thank you so much for sharing today with Chat Bites. I really appreciate it.
Well, thank you for having me. I enjoyed it.
That was Chris Mildner, Senior Philanthropy Analyst at Legacy Health. For more prospect research resources, join us in the Resource Collections community at prospectresearchinstitute.org.